I am from Patterson. I have a little bit of a different population, but I've worked everywhere from the community hospital in the suburbs to where I am now in an urban population. So today I'm going to talk to you a little about adolescent sexually transmitted infections. And this crosses all populations. This crosses all demographics, all areas, and it's important for all of us as providers to know. I have no disclosures. So what do you think of when I say sexually transmitted infection? What comes to mind? I asked myself this question when I was asked to give this lecture, and these are the first words that pop into my mind. STD, gonorrhea, chlamydia, syphilis, HPV, chancroid herpes. These are the common things that spring into our head. This is not a new problem by any means. These are some things from World War II, this first ad. And they gave helpful advice to soldiers that, prostitutes, good time girls, could give you a venereal disease. You can't defeat the Axis if you have VD. But how far have we really come from the 1940s? How far have we advanced in our technology? We do amazing things every day in our clinics and our hospitals that in the 1940s people wouldn't have dreamed of. But you look at these posters, and they're saying the same things. Avoid exposure. Avoid prostitutes. If you're going to have sex with a prostitute, use prophylaxis. And if something bad happens, see a medical professional. This is the same stuff we're talking about currently now in 2016. So today my objectives are, I want to discuss with you who's at risk. Who should we be testing? How should we be testing them? What should we be testing for? And how should we be treating them? Now, this is a very, very broad topic. We can't possibly cover all of it, so I tried to summarize it as best I could. And what I want to convey to you is why it's important to all of us. How many of you here just take care of adults, by a show of hands? How many care for children? Okay, so this is important to all of us. Okay. The CDC found that 50% of new STDs are found in ages 15 to 24. So that demographic spans all of our patient populations. But you will see it in ages from 12, 13 up until the greater than 65 still occurring in nursing homes. So regardless of where you practice, this is going to affect you. This is why I bring it up for these demographics. This is from the Society of Sexually Transmitted Infections. If you look over here at the graph, this shows the amount of sexually active females by age, and the percentages on this y-axis. So by age 16, approximately 50% of female adolescents are sexually active. The number jumps up to 80% by about 18. It's a lot of patients that we're treating and that we're not necessarily asking what their behaviors are, what they're doing, how they're trying to prevent it. The males are similar. They get started a little bit earlier, and there is a little bit of discrepancy amongst the males. These are broken down into overall is this line here, the non-Hispanic whites, the non-Hispanic blacks, and the Mexican Americans is the other line. There is a little bit of discrepancy amongst the non-Hispanic blacks, that they do have a little bit higher prevalence of becoming sexually active a little bit earlier. So who should we be screening? We know that they're sexually active. We know that children actually are starting to have sex at earlier ages, but they're afraid to talk to people. And we are their healthcare providers, and we should be advocating for them and trying to help them. But where do we start? It's overwhelming. The American Academy of Pediatrics put out their policy statement looking at the screening for non-viral sexually transmitted infections in adolescents and young adults. And what they recommended was in our private practices, between the ages of 13 and 15, there should be at least one visit for reproductive and sexual health, meaning a visit just to talk about sexually transmitted infections, prophylaxis, pregnancy prevention. And that's great for all of us in the primary care in the offices. People like me in the emergency room, this isn't really my forte, my area, nor do I have the time to do this. So what recommendations do they have for everyone else? What they said was the guidelines that the health supervision recommended chlamydia and gonorrhea screening as appropriate in your patient population and clinical setting. Now that doesn't tell me a whole lot. Thankfully, where I work now, my patients are very open to talking about this. Parents are very open to talking about this where I work. But I understand I'm at one end of the bell curve where I work. Where I used to work, it was something hush-hush, kids wouldn't talk to parents, they'd lie to you openly about it. But who should we be screening? Who should we be focusing our efforts on? So there have been some articles that have come out recently over the past 5 years looking at how do we risk stratify, which patients should we be targeting. This one came out of the Archives of Sexual Behavior in 2015, and it looked at patterns of adolescent sexual behavior, and it was trying to predict which young adults are more likely to be sexually active and which young adults are most likely to get an STD. And what they found was patients most likely to be sexually active were ones with higher risk behaviors. Substance abuse was being the biggest. The second factor they found was psychiatric diseases, most likely depression. They were more likely to engage in sexual activity at earlier ages. As far as sexually transmitted infections, the starting point that they found in this was female behavior is consistent among all classes. So whether the females display high-risk behavior or low-risk behavior, they were at the same risk of having a sexually transmitted infection. Males were not as consistent, were more consistent rather, in the higher risk groups being more prone to have a sexually transmitted infection. About 10, 15 years ago, someone published a very large study trying to put together a screening tool. What could we be using in our clinics, in our waiting rooms, trying to find out who's more at risk, who's higher risk. But this questionnaire was very cumbersome. It was very long. It was hard to get patients to take it and then for us to apply the results. So in 2015, this came out in Clinical Pediatrics. They tried to take that and trim it down so that we could have something that we could use a little bit easier. And this is the study they published that came out of it. And what it looked at was sexual behavior and asking this simple questionnaire 4 questions, which we'll go to on the next slide so you can see it a little clearer. But what they looked at was, first they asked, the first question was, have you engaged in any oral, vaginal, or anal sex in the past year or in your life? If the answer was no, they were low risk. They went all the way down, they're pretty low risk. The second one, they went to just vaginal or anal sex, again, staying in the higher risk if the answer is yes. They ask if they've used a condom every single time they've had sex. And this is, again, a decision tree point. And then the last question, which I found a little bit surprising, was have all or almost all of your friends had sex? And when they look at this, they break you down your higher risks. Now, this may seem like, of course, if all of your friends are sexually active, if you're not using a condom, you're at high risk for an STD. But this was just a first step in validating a tool that we can use, and at least to open that dialogue. Sometimes it's easier for an adolescent to write on a piece of paper, yes, I'm sexually active, than to look you, the big scary adult in the room, and say, yes, I am. If you have this piece of paper, it makes it a little bit easier for them to say those things, or write those things rather, and for you to intervene and help. So boiled down to these questions here, have you engaged in oral, vaginal, or anal sex? Have you used a condom? And have almost all or all of your friends had some sort of sexual relations? They found in studies the amount of children, and starting, and I say children because they're mostly 12, 13, 14 is some of the starting ages now, has drastically increased. So whether it's just we're getting better for screening and asking these questions, I'm not quite sure, but that's a very scary age to start seeing a lot of these behaviors. So who should we be screening? Who should we be reaching out to? Really, it's everyone. After going through a literature search, I have no real great information for you except we should be asking everyone. All of our patients, start the dialogue, at least bring it up. We can't help them if we don't ask the questions. But sounds easy enough. Let's ask everybody, but what are the barriers? You and I all know that there's pressures to see more patients, see them faster, see them better, see them quicker. We don't always have time to stop and do these things. People in their outpatient clinics, do you really have an extra 5 minutes to have this conversation on your already too short visit? You don't. We have a lot of barriers. Our barriers are time. Our barriers are it's an uncomfortable conversation. Our patients don't necessarily want to talk to us about this, nor Do we always want to talk to them about it? They're adolescents. You're a scary adult. You're the judgy doctor, nurse practitioner, PA that they're seeing that they don't know really well. They also are concerned about their parents. Are their parents going to find out? Are you going to tell their parents? Can their mom that you kicked out hear through the door what they're saying to you? Can they afford it? Can they afford to be treated? Do they know where to be treated? These are all the big barriers that we face every day as providers. So the first thing that always comes up is parental consent. I was at work the other day. I had my first patient at 7 a.m. came in for a pregnancy test, told me she thought she might have an STD. So my nurse had already done the pregnancy test. She was found to be not pregnant. So I had a nurse that kept telling me, Dr. Flannery, did you call the parents yet? Did you call the parents yet? And I said, no, I didn't call the parents yet. No, I'm not calling the parents. And she kept pushing. Why didn't you call the parents? Are you going to call the parents? She was 16 years old. Not going to call the parents. She's like, but she's not pregnant. She's not emancipated. You can't. The question, we have to remember with our common sense hat on, although that's the way a lot of we're set up to ask for consent. If I came in, called the parent and said, your daughter came in here for a pregnancy test today and it was negative, I just violated the confidentiality that we're promising them. So these are the numbers we think about a lot. Age 16 is typically what we think about the age to give consent. In the state of New Jersey, there was actually a bill that passed in 2006 that allowed people starting at the age of 13, could seek HIV and AIDS testing without parental consent. And this can also be extrapolated into looking for other sexually transmitted infections and looking for pregnancy. So know that at the age of 13, you do not have to call their parents. You do not have to speak to their parents. You do not have to tell their parents, which I know it may create some sticky situations for you, the provider, having to have these conversations or kind of sugarcoat to the parent that that's what's going on or what you're doing, but know that we want these patients to know they can trust us and that they have the rights to do that. So the next barrier I see a lot, or I find a lot, and I'm sure you all do, is testing. So now I finally am sitting down with my 16, my 18, my 22-year-old patient. They're telling me they've had pelvic pain for a couple days, weeks, years, however long, and I expressed my concern that they could have a sexually transmitted infection. So they agree to talk to me about it. We decide we're going to test them, and then I tell them how I'm going to test for it. Now, many 14, 16, 18, 20-year-old girls have never been to the gynecologist. Many of them have never had a pelvic exam. So when I tell them that I'm going to put a speculum where and then put a swab somewhere else, people get very uncomfortable, and that's when they start to refuse it. And you all know in your place of work, people very quickly go, oh, patient reviews pelvic, don't have to do it, going to move on, don't have to do it, moving right along. It happens. We laugh, but it happens. But we have to kind of stop and remember that we're there to help them, and are we looking for the causes? And is there a better way of things we can do? What if I told you we could, instead of putting a speculum where and sticking a swab inside, you give me a urine sample, and I could do the same test? Do you think you'd be more likely to order it? Do you think your patients would be more likely to have it done? The answer is yes. Studies have shown patients are more likely to give a urine sample than they are to agree to a pelvic exam. Per the manufacturers who do these urine PCRs, they say they're just as specific and sensitive as the swabs are. Now, the literature tends to agree, looking at for chlamydia. This is a systematic review that came out about a year or two ago, looking at how the non-invasive testing, this one specifically looked at the urine PCR for chlamydia and gonorrhea. And what they found, they pulled about 300 articles to look as a systematic review. And they found chlamydia, yes, head-to-head, the nucleotide amplification testing and the urine PCR testing were head-to-head identical. The gonorrhea, from the studies they pulled, they couldn't say they were equivocal. So they said, jury's still out on gonorrhea, but chlamydia definitely. This article I also found, they found rather interesting because I never thought about it. But there are many studies similar to this going back to like the 60s and 70s actually, of a self-collected swab for chlamydia and gonorrhea. It's as simple as that. You hand your patient the swab and you say, please give me the sample and I'll run it. And they found it works pretty well. Had pretty good sensitivity and specificity for diagnosing a sexually transmitted infection. So just know you have other tools in your arsenal rather than saying, put your feet up in these stirrups, I'm going to put the speculum in. There are other things we can be doing. So what should we be testing? In this talk, I'm focusing mostly on the curable, non-viral sexually transmitted infections, because that's what we're trying to work on as providers. We don't really have a cure or anything to do for HPV at this point in time. HIV is something we're managing. Herpes, again, is a management issue. These are the things that the CDC finds important enough to report, the reportable diseases. They should all be reported within 24 hours of you coming up with a diagnosis. And you should speak to your institution, your labs, to see whose responsibility it is for reporting. New Jersey adds a few more to the list. They look at, specifically too, they have the hepatitis for both active and chronic infections should be reported. They also, as far as chlamydia, they want neonatal and adult reported, and then syphilis. So why do we focus so much on these? Why do we focus on chlamydia? We focus on it because it's everywhere, and we have a treatment for it. This is something we can fix. Okay, we talk about managing HIV, we talk about monitoring for HPV, we talk about vaccination for HPV, but we don't really have answers, solutions, we don't have cures for these yet. But this is something we have a cure for. I was surprised to pull this data, this came from the CDC, to look at where chlamydia is in the numbers. I was pleasantly surprised to find New Jersey to be in the white area with only 2,500 cases. But then I stopped and I said, okay, well, how often do myself or my partners who work in a fairly high-risk area actually obtain these testing? And how often do we just treat patients because they're not always reliable? So I think there might be a little bit of bias in these graphs, but no, it's everywhere, and we can fix it. Flashbacks to pathology, they're diplococci there and gonorrhea. This is showing the rates of gonorrhea per 100,000 people in our population, and this is just females on the right and men on the left. So you can see again here the illustration. It's occurring from ages 10 to 14 all the way down to 65 plus. So wherever you guys practice, it's in your area. Obviously the largest distribution is in this younger generation here, which we're really trying to target. And I'd be failing if I didn't admit the new STD that people keep to mention as I go to conferences and lectures, of Mycoplasma genitalium. It's not actually as new. I think we've just started to speak about it more in our literature. It actually was discovered first in 1980. And when they found it, they weren't really sure if it did anything. They weren't really sure if it was sexually transmitted or what we should be doing with it. The past few years, more literature has been coming out. It's been being studied a little more. It's been being tested for a little bit more. And what they've actually found is it is as prevalent as chlamydia. So when they started swabbing people and looking for it, as many patients had chlamydia had Mycoplasma genitalium. They found it in both men and women, and they found it in both sexual partners, that leading them to extrapolate it is sexually transmitted. And it's a huge cause of urethritis and cervicitis. So how do we treat it? Now, I know most institutions aren't actively treating for this. This isn't in your drop box, your checkoff box, in your lab forms. So I looked around trying to see what some recommendations are for us in treating this. And what they really found was people that have recurrent urethritis, cervicitis, it's something you should kind of be considering in the back of your mind. Maybe it's something else we're missing, we're not treating. They're not necessarily just being reinfected. Maybe we're just not clearing the actual pathogen that's to blame. And what they suggested was, if you keep having someone coming back and coming back, perhaps if you haven't used azithromycin yet, give them another dose, or give them a dose, or go to moxifloxacin. That would be what they recommended. So we're getting there. We're getting to treatment. That I would have to check for you, but yes, I assume it is. But that article only looked at, that I pulled up only looked at that. But so treatment. The reason I bring up treatment is because we all think we're good at this. I know myself, it's, oh, I can give you a gram of azithro and give you a shot of Herceptin and I'm done. But it turns out, when you look at the literature, we're not very good at the diagnosis, and we're not very good at the treatment either. Because a lot of these diseases, you have to know what we're treating, because the treatment varies based on what we're treating. And it's all slightly different. It all sounds the same, with a change in the duration, a change in the dosage. So that's where we're going to review a couple of these right now. So bacterial vaginosis, we all learn in medical school, it's caused by trich. It's the classic for vaginal itching, foul smelling, frothy discharge. It's foamy. Those are those clue cells. You can have flashbacks to your boards. The reason why I bring it up is because it's very important. We don't always ask the questions. We don't always do the pelvic exam. But it's very important that we be finding more cases of bacterial vaginosis and treating them. It is transmitted from partner to partner, but it's very easy to treat. And when you treat it, it goes away. If you don't treat it, it makes these patients much more prone to getting a more severe sexually transmitted infection like HIV, gonorrhea, herpes, chlamydia. So looking at this, the treatments that are published, all my treatments on the next slides are from the CDC's website, what they recommend. But important for bacterial vaginosis is these are some tough meds to take. Just make sure you're talking to your patients. Is this patient a college student that's going out 4 nights a week to the bar? Well, maybe metronidazole is not the choice for them, and maybe they should be on something a little bit different. Maybe your patient's prone to have a lot of belly pain, and you don't want to give them clindamycin. Maybe you don't want to give them either oral medicine, even though we think it's a great idea, and you want to switch them to a gel. So moving on to chlamydia and gonorrhea causing pelvic inflammatory disease. Pelvic inflammatory disease is actually a large, broad topic. It's anything in the pelvic area causing inflammation. This can include endometritis, salpingitis, tubovarian abscesses can all cause these things. For diagnosis, the quick and dirty thing to remember: pelvic pain, uterine tenderness, adnexal tenderness, cervical motion tenderness. So if you have pelvic pain plus any of those three, you can safely diagnose your patient with PID. Looking at further studies, they have things you can look at things as far as white counts, temperatures over 101, CBCs. Those things can all help make a more sensitive diagnosis. But for common practice, this is safe enough to diagnose. Patients that are well-appearing, non-toxic, are safe to discharge home on oral therapy after they've been treated in your clinic with IM ceftriaxone. The reason why I point this out is these should be treated with the ceftriaxone, but it's a 14-day course of doxycycline for PID, per the CDC. And then you can consider adding the metronidazole. Again, in your sicker patients, your patients look more toxic. These are patients that are going to be candidates for inpatient treatment, observation, OB/GYN consults. And these patients are the ones you're going to recognize off the top of the bat. They're your toxic-looking patients, your patients with high fevers, your patients who have failed outpatient management, patients that you've diagnosed tubovarian abscess, patients that you don't think are able to tolerate their medications at home, and pregnancy. Pregnancy would be the biggest reason for inpatient therapy. There's a very high morbidity for patients that have PID in pregnancy, and they also have a higher risk of preterm labor after having. So urethritis, most commonly caused by chlamydia, gonorrhea, and mycoplasma genitalium. Diagnoses we can make depending on where your area of practice is. You can make it based on the purulent discharge if you notice it. You can do a gram stain of the secretions, and if there's greater than 5 WBCs, it's most sensitive. If you have a first void urine with either leukocyte esterase or greater than 10 white blood cells, you can pretty much diagnose it. And then you can do the standard testing with a swab for the AAT testing. The one that's most preferred is the blue, the gram stain of the urethral secretions. And the treatment for this one is a little bit different than before. Urethritis, it's the ceftriaxone plus the PO dose of Zithro, and this is where you get the choice. I think this is where people get confused between PID and urethritis treatment, because this is where it occurs. But note that this doxy is for 7 days versus the 14 in the previous slides. Patients come back. We did touch on this earlier about patients coming back for repeat symptoms, not clearing it. The first question is always to discuss with the patient, have all of your sexual partners been treated? This happens more commonly than you would think, that patients come back and you ask them, well, did your boyfriend, girlfriend, so-and-so get treated? No. Well, you have another infection because they gave back to you. So it's very important to discuss with them, has the partner been retreated? Has the partner, been treated the first time? Depending on where you practice, it's very controversial whether or not we should be sending them home with partner treatment or not, or just recommending them to come back, and that's really up to your comfort level. If they do come back to you with persistent symptoms, the partner has been treated or hasn't been treated, you have to start thinking about some other medications. The metronidazole at this point, just a PO dose one time. You can add tindiazole, but plus azithromycin. Cervicitis, same bugs causing this one. Two things to look for: purulent discharge in the canal and easy endocervical bleeding. So if you are doing your pelvic exam and you notice when you go clean with your cotton tip, the cervix is very friable, it bleeds very easily, you should have a higher suspicion for cervicitis. You should also ask your patient, are they having easy bleeding after sexual intercourse? That's also a sign they could also have cervicitis. And the treatment's similar to the one on the previous slide, but CD recommendations are a little bit different. Same meds, but in a different order. They always say to consider ceftriaxone, but primarily they're recommending treatment with the azithro or the doxy, and then to consider it. I'd recommend if you're just treating empirically, that you would absolutely give the ceftriaxone. If you're treating, you have your cultures, your sensitivities in front of you, obviously that's a little bit easier to make your antibiotic selection. And as we harped on before, you should be testing all partners. So in summary, have a conversation with your patients. Open the dialogue, whether it's letting them fill out a survey in your waiting room or a screening thing that they just have to check off and not actually speak to you, but can let them open that dialogue. Have the conversation. Let them know you're there to help them. Let you know they're there to advocate for them. The CDC recommends routinely screening for chlamydia in all sexually active females less than 25 years annually. The same thing for gonorrhea, anyone female less than 25 annually. Men, a little bit different. They're more just a high-risk behavior, or as you see fit, they recommend testing for either sexually transmitted infection. Consider empirically treating your patients, and make sure you test all partners. Thank you for your time. Yes, sir.
In my practice, I see everybody of every age once a year for a physical, kicking, screaming, whatever. Starting about 12 or 13, depending on the maturity level, the parents' level, I start to talk to them about, start to talk to them about the prevention of sexually transmitted disease. Open the dialogue with the parent right there. 99 times out of 100, the parents right there, they're so glad I'm doing it, and it's reinforcing what they bring up at home. The one thing that I didn't really hear a lot about was herpes, because we talk a lot about that, and people tend to think of it as a genital-to-genital spread as opposed to mouth-to-genitals, which is probably what happens more often than not. So, we have to involve the mouth-to-genital conversation. And, sometimes kids are embarrassed, but parents really appreciate you bringing it up. And I think that because 90% of the population by age 65 has it recurrent in their mouth, chances are there's interaction throughout the life cycle that's negative. So I see it in couples, and I try to prevent it from the word go.
Absolutely. That's the best thing you can be doing. I tell every patient I have when I see them to tell the parent I have them leave, and I tell them everyone over the age of 12 is talking by themselves for a few minutes, and it doesn't matter if they're there for an ankle sprain or for whatever, and you have that dialogue with them. I think that's great that you're doing that.